Thanks again for the invite. Doncaster definitely brings back memories. This was where I took my first job as a registrar, so where I dealt with emergencies firsthand. So it does bring back lots of memories, and obviously lots of things have changed. You know, the postgrad center has changed, and so it's quite good being back here again. What I'm going to talk about is emergencies in the head and neck cancer clinic, and obviously that's probably not what you expect because you're in a clinic, you don't expect to see emergencies, and probably a lot of what I talk about would be anticipating things, and I think that theme has actually come out in a lot of the talks that you've probably heard today. So this is our clinic in Chesterfield. The first picture there is just the main entrance, and that's the waiting area. And I would try and tell my talk along airway, breathing, circulation, and disability and dysfunction, just to try and help you to think about certain things that would possibly cause problems subsequently down the line, but may not necessarily cause a problem while you're there in clinic. And so I've taken the opportunity to, and I hope this doesn't insult your intelligence, just refresh what an emergency is. Remember, it's serious. It's something that you weren't planning for, and it's something that definitely needs immediate action. What I've done is when our bodies are stressed, we have a way of reacting to things, and you've got these alarm reaction, resistance, and exhaustion. And what if you look very carefully at this, most of the time we can compensate, but somewhere towards the end, towards the end there, if we don't compensate satisfactorily or properly well enough, then that's when big problems happen. And what you want to do is to be able to intervene, preferably there, or worst case scenario there. And so I'm going to try and talk about the things that you would see in clinic, and hopefully that would help you to intervene at the blue spot there, or the blue arrow there, or worst case scenario at the purple arrow there. So once again, like I said, it's anticipation, and as you know, that's probably the motto for Boy Scouts, being prepared. So I would go through causes, assessment, management of all the possible scenarios that I would probably possibly think about, and I'll start off with the airway. So Stridor, Stertor, don't forget that there's a difference between both. Stridor usually happens at the level of your larynx, Stertor much higher. And a lot of time in your head and neck cancer clinic, you'll see stoma patients, and one of the things I'm going to talk about is problems you can get with these, and your post-radiotherapy patients, because as you can imagine, particularly in the first few weeks after radiotherapy, they are liable to get problems which you would like to pick up as quickly as possible. And these are situations where you'll probably get, airway problems. So the oral cavity, the oral pharynx, laryngeal neoplasms, and with the airway talks today, you had quite a few of those. I've put that video there, and you would probably see a little bit of an airway problem there. Lymphomas, very, very common because these are very massive tumors. They grow very fast and very likely to cause airway problems. You've got parapharyngeal masses, nasopharyngeal masses, and your thyroid neoplasms, although not common, where you get all these big problems, but you can get pressure symptoms. Occasionally you get invasive disease that can cause airway problems, and definitely subglottic stenosis. Most of the time they'll come in and you can hear it from their voice or from their very slight stridor. You want to try and pick up these things way before they present down to your accident and emergency department. And you can see from that video that the right cord there is not moving as well as the other one, and you can't really see down into the subglottis as you should be able to, and that patient is definitely going to have a problem somewhere down the line. Now, I was talking about the stoma patients. So you've got microstomia. If patients present with that, just anticipate, all it takes is for this guy to have a little bit of crust and mucus in that place, and he's definitely going to have an airway problem. Their accessories can cause problems, particularly with patients who are not very careful or who probably don't understand things with the accessories very well. And then tracheostomy patients, you could have a tracheostomy patient who has a dislodged tracheostomy. That's probably not common if they've had a very established tracheostomy because the tract's very nicely formed, but in the very early days, a few months, it's possible that, the tracheostomy tube might be out and they have problems and things like that. After radiotherapy can be a problem, and if anybody's attended this before, you probably might be familiar with this very dramatic video. So that's the nasal cavity there. This is a lady who had radiotherapy for, I think it's a tonsillar or tongue-based cancer, I can't remember. And we're just short of the nasopharynx, going down to the pharynx at the level of the tonsils there. And you can see a significant constrictor narrowing there. And she definitely had an airway problem, except she opens her mouth. And if you look very carefully, you see what happens the moment I actually manage to just go. So the moment you actually just go through that, what I would call a pinhole, you see a normal airway. But the problem is actually getting air past that point. And you can see I've had to quickly pull out the laryngoscope because she barely couldn't tolerate that at all. And this lady very unfortunately ended up with a permanent tracheostomy despite my best intentions. All attempts to dilate that failed. So patients do have problems, and this is another thing I must say about this. This actually happened 4 years after radiotherapy. So she was absolutely fine before then. So it's just thinking about these things. So it was a delayed radiotherapy reaction. It's thinking about these things and how they can cause problems down the line. This is another patient. He had actually had radiotherapy. I don't know if that's plain or not. It is, but and he had had radiotherapy probably about, say, 2 or 3 months after this. I'm sorry the video is a bit slow, so you, for some reason it's, but once again, an airway problem. As you can see, he's got lots of thick mucus. His epiglottis is rather swollen. There's no recurrent disease or anything there. But these are problems. These are kind of things that you want to pick up in clinic before you get any problems. Then bleeding. So that's all through your airway. Patients with nasopharyngeal tumors, juvenile angiofibromas, particularly if you're biopsying them, obviously, which is something you probably don't want to do, they can bleed, but then they can actually decide to bleed while you're there on clinic. Supraglottic tumors can bleed, and exposed neck wounds. So you get somebody who comes in, their wound is very nicely covered up, and you might decide to just have a look at it, and lo and behold, they could bleed right there at you. Iatrogenic bleeds can happen from, core needle biopsies. A lot of us are doing core needle biopsies rather than FNAs these days, and you'd discover that a lot of your radiologists will check whether these patients are actually on anticoagulants, because if they are, you probably want to think twice about biopsying them. I do a lot of biopsies of the tonsil in clinic because many times it saves me from having to do a pan endoscopy, particularly when I'm quite sure that their disease is limited to the tongue base or to the tonsil, and they are going to have chemotherapy. If they're thinking about surgery, then yes, definitely they do need a pan endoscopy. And one thing to ask is, are they on anticoagulants? Because if they are, I think you want to think twice about biopsying these patients in clinic. But yes, they can bleed, and they can bleed very, very badly in clinic. And then disability, nerves. One thing out, you've got these nerves: optic nerve, facial nerve, your spinal accessory nerve. That's not uncommon in particularly patients who've had surgery. And one of the things with the spinal accessory nerve is detecting it early is probably the key here. Most of the problems you get with the spinal accessory nerve is not detecting it at all, and then 3, 4, 5, 6 months down the line, that's when it's detected, and then the damage is already done. Your hypoglossal nerve, these are things you want to check and find out that patients don't have problems in these areas right there in clinic. Patients could have raised intracranial pressure for whatever reason, for sinonasal tumors. They could have metastatic disease to the brain, which is not common. They might have CSF leaks, particularly if they have sinonasal tumors, something you'd like to pick up in clinic. A lot of us these days are treating patients with primary hyperparathyroidism. And once again, patients who have very, very raised calcium levels, particularly above 3.5, would usually be an emergency that you want to pick up, although I acknowledge the fact that a lot of these patients might be presenting to your endocrinologist first. Vasovagal shock is not uncommon for all sorts of reasons, ranging from a very innocent thing to just telling a patient about a parotidectomy and mentioning the facial nerve that they could have a facial weakness and they just passing out, or just telling somebody that they've got cancer can give people vasovagal shocks. And just thinking about the drugs that you are using in clinic, very rarely some of these things can cause reactions that could lead to things, situations where you might need to deal with an emergency. So how do you assess these patients? It's being very, very, very observant, because most of the time, these are not your frank emergencies like you've been dealing with all day. All the talk you've heard, a lot of the pictures I've seen there, there's a pretty straightforward, well, not straightforward, but emergencies that you can see there. And then most of these cases are the very, very subtle cases. And like I said, the decompensation hasn't happened, nothing's happened. So you really just need to keep your eye out here. You want to ask, you want to look, you want to listen, you want to observe. Things like snoring, where they're not snoring before, now snoring, they're short of breath. How have they come into your consulting room? Have they been wheeled in a chair? Do they have stridor? And sometimes if you listen very carefully, you get those very, very little things. So it's worthwhile just trying to pick these things. For stoma patients, it should be routine, checking if their valves are working. So a valve that was working before, somebody who could talk before, all of a sudden they can't talk. Think about what might be happening. Could it be that the valve's displaced, leaking valves, laryngectomy accessories or the valve accessories? Is there anything that's missing that might be in the trachea? And the tracheoscopy is your definite way of finding things like that out. Impending bleed should be obvious most of the time, and like I said, it's just thinking about what you want to do to patients to prevent that. And once again, like I said before, it's checking the drugs that your patients are on before doing anything active to them in clinic. And then you've got the nerves, your facial nerve once again, so grade your facial nerve weakness so you can compare if they come back. For patients who've got salivary gland lumps, always anticipate, so check the facial nerve. And for patients who are going to have elective surgery, tell them about the possibility of things getting bigger, their skin could be involved, anything could happen. And if these things happen, they do want to come back because it just might mean that, something that was benign and straightforward is actually getting worse. You can have tumors that are pressing on your optic nerve, so, just check these nerves. Patients who've got Graves' disease, and once again, I acknowledge that a lot of these patients will probably be presenting to the endocrinologist, but it's something to watch out for. And for patients who've got hypoglossal nerve problems, they might not be eating properly, they might be dehydrated, they might be a little bit dry. Just looking at their tongues, just checking their, what they're like generally does help you, assess where their oral intake is great or not. You would all be very familiar with the fact that, we constantly check whether patients are aspirating. You want to get your speech therapist involved because obviously when they get chest infections, things are obviously worse. And same thing with patients who might have bilateral vocal cord palsies, who could end up with stridor with the bilateral palsy and things like that. So it's worthwhile just checking these things with all these patients. And I've just got that slide there. Once again, like I said, CSF leaks, usually nasal tumors. If they've got, anything there, send their fluid off for beta transferrin. And I have mentioned vasovagal shock from, bad news or overwhelming news. And, get the odd occasion where just even passing a flexible nasal endoscope down somebody's nose makes them pass out. It's just worth something thinking about. Going on with the assessment, so we've talked about the hypercalcemia symptoms, and the symptoms with hypercalcemia are just wide-ranging. Don't forget that primary hyperparathyroidism is where you have inappropriate PTH elevation. So, obviously your calcium is usually high, your PTH is usually high, but then, your calcium may not necessarily be very high. It's inappropriate. So it might just be at the high end of normal. With a very big PTH, but definitely these may not cause emergencies. And then you've got the ones where you get the normal PTH, and that's where you start, suspecting where they've got distant malignant disease somewhere else. So managing these patients, and I think you've heard a lot about that all through today. One of the very important things is, so remember we're talking about patients who actually haven't yet developed a problem, but can develop problems. And if you've made that decision to send them home, it's so important to appropriately counsel them so that they're aware of what could happen. That's number one. Number two is, when you do a letter, or when I do a letter, what I then try to do is make sure that they have my clinic letter in the notes as quickly as possible. So that's one letter I'd want to do, and make sure that it's there within a day, probably 2 at the most. So just in case this patient comes back to A&E, it might be somebody that you prefer they don't have a tracheostomy. It might be that you have a preferred management plan for them. If you haven't got that plan into the notes, it's very difficult for anybody to know. So the first or the second video I showed, for example, he was somebody who had had an acute radiotherapy reaction. I was almost quite certain he was going to do well without a tracheostomy. I think he actually went to Sheffield at some point. And if I'm not wrong, I think, Paul, you probably spoke to me about this chap. It's worthwhile having these patients' clinic notes in the notes so that people are aware, or everybody who sees this patient is aware of what you want to do. And a lot of the stuff I've put there is probably a lot of what you've heard today, including the airway problem, securing the airway, debulking, tracheostomies, or whatever you choose to do. And I think you've heard quite so much about the different options there. Troubleshooting your tracheoesophageal speaking valve problems. So, each patient that comes your way, troubleshoot their problems, check, are they still speaking as usual? Is the valve blocked? Is there a leak around the valve? Check all these things. Most of these patients should be, they should be able to tell you, very easily where there's any trouble with their valves or not. So problems around, leakage through the valves, leakage around their prostheses. Is the valve too small? Is it too big? Is it just moving in and out? Is it a nice snuggly fit? So check all these things. If you've got a loose valve, then that's more likely to come out at some point. And like I said before, does your patient still have a voice? And if they don't, then you'd be sure that, something, it's either the valve's coming out, it's blocked, or something like that. And there are lots of things that you can do with these valves in clinic to make sure they enter problems. A lot of these are Blomsinger accessories. These are things that you can use to lock around the valve, if you've got any of these problems with your valves. And if everything fails, if you're on your own and you really don't know what to do, a simple Foley's catheter, usually through the fistula, and then coming back to main clinic, usually, helps you most of the time. Bleeding, that's a patient who had a neck dissection, had recurrent neck disease, I think had a pectoralis major, had a further operation, had a pectoralis major flap, which unfortunately failed, and you can see, she's got disease all over there. So it's just worthwhile anticipating these things in clinic, and I'm sure you heard, I think you heard in one of the other, talks, anticipate these things, think about them, don't send this lady home. Sit them down, talk them through this, it's inevitable, it's going to happen, so don't run away from it, and talk them through what, needs to happen. Can they manage this at home? Can they, don't run away from these things, don't get scared about it. Talk to patients about it. I think I've talked about biopsies, think very carefully about whether patients can have biopsies in clinic before you do them. Nerve palsies, consider expediting definitive treatment, particularly patients who've got parotid disease. If they have facial nerve palsy, obviously you want to treat them in time. And I have talked about the accessory nerve. It's so important to, most of the time the accessory nerve trouble that you get is a neuropraxia, and it's getting them rehabilitated in time. That's really the issue. Most of the issues that we see is because they're not detected until several months down the line, and that's when you have problems. If you have patients who have incompetent larynxes after radiotherapy, it's important to pick these things in time. Get your speech therapist involved. They might need a peg. They might need a gastric tube feeding until they can get their larynxes working better. Some of them might need to be nil by mouth. They might need thickened fluids. They might be thickened things. But it's important to get these things or pick them up in time. Otherwise, these people come back with chest infections, and the morbidity from that is quite high. Swallowing problems, like I said, once again, get your dietitian involved. The metabolic imbalance from people not eating and drinking properly after radiotherapy is real. Not once, not twice. I have seen patients develop some form of renal failure just because their metabolic imbalance wasn't picked in time. So it's so important to pick these things. We all work in different departments. Some people preempt patients and give them pegs before, some of us don't do it, and whatever the case, if you don't do it at all, then you want to really be on the board and check these patients regularly so that when they have problems, you can pick them up in time before they go past that decompensation phase. Just one slide on hypercalcemia. Below 3 is usually not a problem. I think if it's between 3 and 3.5, it depends on how it's developed. If it's been very slow, then you just might be okay. But most of the time, you want to get your endocrinologist involved with these patients because they have quite a number of things that they can do. Definitely, if it's above 3.5, then the risk of problems is high, and you definitely need to do something to get these patients treated as quickly as possible. And that's a good one slide of, I don't get involved in a lot of these things that patients do. My only role here was to make sure that they have their parathyroid surgery as quickly as possible, which is the last point on the slide there. So your endocrinologist most of the time would be able to do quite a lot to get these patients' calciums down. Coming to the end, make sure that you have resuscitatory equipment in clinic, and make sure that that you work in a place where these things are checked regularly. It's so important to keep all of this in place, so that when you do have vasovagal issues and things like that, you can at least make sure that patients are dealt with promptly. So I said the key points, like I said, it's anticipating. These are not your frank emergencies. These are patients who can potentially develop problems. So it's anticipation, anticipation, anticipation. Think about, these things well and long before they happen. Thank you.